Hello, my name is Dr. James Underberg. I'm a clinical lipidologist and director of the Lipid Clinic at Bellevue Hospital in New York City. We're here today at the Foundation for Health Improvement and Technology, and we're talking about familial hypercholesterolemia, or FH. And my guest today is Dr. Patrick Moriarty. Dr. Moriarty is also a clinical lipidologist, and he directs the lipid program at the University of Kansas, and is also a world-renowned specialist in the area of LDL aphoresis, which is a treatment utilized in the management of patients with severe familial hypercholesterolemia. Thanks for being here with us today.
Thank you, James, for inviting me.
My pleasure. So what we wanted to talk about, obviously, was the role of LDL aphoresis in the management of patients with FH. So I was hoping you could give us a brief overview of the treatment protocol, which patients qualify for it, what some of the side effects are, and some of the issues that might come up in the management of these patients.
Sure. Starting with aphoresis, the first treatment used to remove cholesterol in these patient populations was done in the 60s in a case study performed in France using simple plasma exchange. And this continued on to the early 80s where very selective aphoresis was performed, where instead of removing all the plasma, which simple plasma exchange does, you actually remove specific LDL cholesterols.
Right.
Since the 80s, the guidelines have been developed throughout the world. Unfortunately, they're not consistent in every country that we have, and it's not being used everywhere in the world. But generally speaking, in the United States, the guidelines we have is someone who has an LDL of 200 or more on maximal pharmacotherapy with ongoing cardiovascular disease qualifies for aphoresis. Or a patient who has an LDL greater than 300 milligrams per deciliter who does not have symptomatic disease, but again is on maxed pharmacotherapy, qualifies for aphoresis.
Okay.
And with that being said, in the United States, presently we have about, including Canada, probably 500 patients total that are being treated on LDL aphoresis. In the worldwide, I just did a recent analysis that I estimate only 5,000.
Now, do you think that number is appropriate, or do you think there are people out there who would benefit from it who are not getting access to it or being referred for it?
Well, let me see if you can answer this question. There's not one treatment being performed in South America or Africa.
Okay.
I don't think that's because of lack of FH patient population.
I think we're under-treating.
Yeah, I think we're under-treating. And we estimate, if you look at familial combined dyslipidemia, probably the patient population worldwide is 12 to 30 million potentially. Obviously not these patients are all requiring aphoresis, but there's a large majority of patients that are being appropriately treated aggressively for their risk of the disease.
So those numbers you gave me, 200 and 300, I know that reimbursement often depends on that.
Right.
Would you say that there are patients who maybe are a little below those numbers who might also benefit? I know the NLA has set some cut points, maybe a little lower, trying to capture some people who still might benefit potentially from aphoresis. What's been your experience with that?
Actually, that's correct. And some sites in the United States and Canada do perform aphoresis on patients who are below the standard mark, based more on symptomatic disease in my situation of my patients than on numbers.
Right.
And in Europe, it truly is that way. In Germany, I think the LDL goal is 130
Wow.
with disease, maximal pharmacotherapy. And
I'm sure the state covers everything.
actually in Germany, the state does cover a good percentage of, and recently the state has approved them for not just LDL, but Lp(a) for treatment with symptomatic disease.
So that actually brings up a very important point, which is we were talking earlier about the importance of screening FH patients for elevated Lp(a). I'm sure you see patients like this, and from what I understand, there are patients who may benefit from aphoresis who have isolated levels, severely elevated levels of Lp(a). Can you tell us a little bit about your experience with those patients?
Yes. At our center, we presently treat roughly 3 patients who have symptomatic cardiovascular disease, LDLs less than 70, with LDLs in the hundreds, with Lp(a)s in the hundreds, excuse me. And resistance, obviously, as you know, to pharmacotherapy outside of what we have now, nothing really seems to be a benefit. And they have been doing extremely well on this biweekly therapy. In Europe, once again, Germany, as I mentioned, they have hundreds of patients of this type. And they've published a paper by Beata Roxanne Yeager in a group of all the aphoresis centers in Germany looking at this on patients who had high Lp(a)s, normal LDL, symptomatic disease, followed them for a 5-year period, and found that there was a great reduction of cardiovascular disease events, related to lowering LP(a), irrespective of what the LDL level was.
So there seems to be a benefit from then doing the procedure on these patients.
On these patients with this type of LP(a) with symptomatic disease, I think greatly much so. In fact, in Russia, there's a device that treats only LP(a). They have it. It's an antibody in the filter that attracts itself to LP(a), so it has no effect on LDL. A recent presentation at the AES last year and a recent publication on their work, they did a 2-year study on these patients looking at IVUS, intravascular ultrasound data on the coronary vessels, and they found even though that they didn't lower LDL at all, but by lowering LP(a) by 70%, they significantly improved the intermediate thickness and the plaque volume of these patients over a period of 2 years.
Now, you've obviously had extensive experience with this procedure. I know there are different technologies with regards to the aphoresis process right now, and I know you've had experience with more than one.
Right.
Just a brief overview of what's available out there right now if someone was going for aphoresis. What types of technologies are available?
Well, basically you put them in 3 categories: non-selective, semi-selective, and selective. Non-selective, simple plasma exchange.
Right.
Centrifuge, you separate the red blood cells from the plasma. The plasma then is removed, which controls all the cholesterol, but you lose albumin, electrolytes, and so forth. The second one is semi-selective, and this is a double filtration mechanism where you have filters that have different diameter sizes that through the process you can remove certain proteins based solely on their size.
Right.
And that's a semi-selective because you're still removing proteins some that you might not want.
Right.
And finally, the selective variation. And there you have different types. You have one type based on electric charge, where ApoB is a positive charge molecule. So either through using dextrin sulfate filters that have a negative charge, or putting the plasma in a low pH solution bounded with heparin that precipitates the ApoB, you remove the apolipoproteins proteins quite significantly. And the other selective method is using antibodies to ApoB. Similar to the antibodies to LP(a), they have these sheep antibodies on the filter that binds to the ApoB. Interesting with that system, you can clean it and use the filters over up to about 40 times. The problem with that system is sometimes the individual develops antibodies to the filter itself, so you have to be careful.
Is that because of the immune-mediated process itself?
Yes,
yeah,
yes.
Very interesting.
And then there are 2 systems using whole blood instead of separating the plasma.
All right, so there's really a lot of options out there, right?
There are internationally, but in the United States we have just 2. We have the dextrin sulfate Konica device, liposorber, or we have the Braun HELP system, which are both negative charge.
So any final thoughts, anything you would want our audience to know with regards to aphoresis, the process, referraling, et cetera, that you thought might be important?
Well, the process is kind of complicated because, as I mentioned, there's only 500 patients being treated in North America at the present time, and there are very few sites around. The NLA mentions it in their website, and the FH Foundation also has discussion of it. But if you have a patient who you feel is not getting the goal, who has symptomatic disease, I think it's something that should be looked into. Because reimbursement's there even for Medicare patients at the present time.
Great. Well, thank you very much. This has been very informative.
Thank you.